proceed with caution. This is a very graphic video. If you have a weak stomach, please watch one of my other videos. Thank you. So today we are going to be playing Ed Head's Hip Surgery. So let's get into it. Alright, let's turn on this. Alright. Hip. Click here to begin hip resurfacing surgery. Click here to photos of real hip. Oh, okay, I gotta do this one.
A mission called Total Hip Resurfacing. I'm Dr. Mark, and you will assist me in the operating room. You think you can handle it?
Sure.
Today, our patient is a 55-year-old man with healthy bones and no significant bone loss due to arthritis.
Okay. That's nice.
Because of his young age and normal anatomy, hip resurfacing surgery will preserve more bone than a total hip replacement. Why do you think it's important to preserve bone in younger patients?
They may use up more bone to stay active.
I would not want to be your patient.
As you can see, most of the cartilage or cushion between the bone is gone, especially in this upper portion of the joint.
I don't see it, but okay.
The prosthesis we use during surgery will need to fit our patient. To do this, we use templates that determine the approximate size. Let's start with the acetabulum or cup of the hip. What size do you think fits best?
Sorry, that's wrong.
Great! We now know the size of the acetabulum
My
will
bad.
be 60 millimeters. The femoral head will most likely be 6 millimeters smaller. What size femoral head should we use?
I would not want to
With
be
our
your
templating
patient.
done and our patient prepped and draped, it's time to operate. Scrub in stat.
You're mean.
Use the sterile marker to draw the location for our incision. Now for the incision, grab the scalpel and cut through the skin and subcutaneous layer of fat.
Okay.
Nice slice. Next, cauterize the blood vessels with your Bovie. This will reduce blood flow into the surgical field.
Okay.
Now, we'll soak up the remaining blood using laps. These retractors will hold the skin and fat layers back so we can get to the muscles underneath.
Ugh.
Take the scalpel and cut through the tensor fascia lata and split the gluteus maximus along the fibers of the muscle. Next, cauterize the blood vessels with your Bovie.
Okay, I'm sorry.
Now let's pull back the split using the deep retractors.
Okay, be quiet.
Watch out for the sciatic nerve, which can be felt through the fat. If we damage it, our patient will lose feeling and have difficulty using his leg. I'll use 2 retractors to separate the gluteus medius and expose the piriformis tendon. Then I'll cut the short external rotator muscles and suture them out of the way. See the flexible capsule around the joint? Let's cut open this capsule and hold it back with sutures. I'll need you to dislocate the femoral head. Do this by flexing. Great job. Now we can see the entire femoral head and how arthritic the joint is. Using a sizing gauge, measure the head and neck of the bone. The head size will influence which prosthesis side to use.
Okay.
Seeing we have already templated prior to surgery,
Nice job.
I've estimated the center of the femoral neck and marked the bone using a Bovie cautery device. Now place the guide wire, and I'll confirm that the position is accurate in 3 ways. First, the alignment guide shows that we have found the center of the neck, and not just the center of the head. Second, if we centered the guide wire properly, this feeler gauge should rotate freely around the neck of the femur, which it does. Third, I'll finish placing the guide wire and check to see where it exits the bone. Why are so many steps taken to ensure again? Good job. Grab your drill and pass it over the guide wire. Prepare the femoral head for the guide rod. And make sure you don't go... That's some good drilling. Place the guide rod over the guide wire until the collar is flush. Good job. To fit the prosthesis, we need to shape the outside of the femoral head with the cylindrical reamer one size larger than our prosthesis.
Oh my god.
Your mom would be so proud right now.
No, she wouldn't.
With a smaller reamer. Great. We have changed the diameter of the femoral head to the correct size. The next step is to shape the top of the femoral head with a hemispherical reamer. This reamer will allow for a tight fit.
Oh my god.
You're a natural.
That's
Before we fit the
nasty.
trial component, take the rongeur and cut off the small amount of bone. Then place the trial component on the prepared bone.
Oh my gosh.
Fits like a glove. Good work. The head diameter is larger than the component used in traditional total hip replacement. Why will a larger head? That's correct. In order to make room for work on the acetabulum, we will move the femoral head into the pocket created in front of the
I don't know what this
acetabulum.
even means.
This allows us to see the acetabulum clearly for the next step. During pre-op planning, we chose a 60mm prosthesis cup for the acetabulum. We will need to gradually increase our reamer size to prepare the cup for the right component. Generally, a cup 1 to 2 millimeters larger than the final reamer size is inserted for a good fit.
Ow.
You've done this before, haven't you? I
No.
will finish preparing the acetabulum
No.
for the prosthesis cup with a size 58mm reamer. Now we mount the
No.
cup on an insertion device, which also serves as a guide to help find the correct orientation. Align the device with the lines shown. Tap the cup into the acetabulum until the bone completely surrounds the edge of. Before we test the prosthesis, we need to remove any bone spurs using the rongeur.
Oh.
Time to test the prosthesis for stability. If the hip is able to move freely, then we know the prosthesis is not likely to dislocate. I will pick up the leg and make sure it straightens all the way. Then rotate the foot and knee out and away. Then rotate the leg inward. Finally, push the leg up. This test shows good range of motion and hip stability.
Good job,
It
Sal.
looks great. Okay, let's put the real prosthesis in. First, we'll dislocate the femoral head and remove the trial prosthesis. Now we're ready to cement in the permanent femoral prosthesis. Use the burr to create a small trough. Why do we need to make a small trough? Grab some cement and spread it onto the femoral head.
Oh.
Then use the impaction device to gently tap the prosthesis in place. Now we'll wait for the cement to harden. I will put the hip back into place and check range of motion one more time. Nice job. Time to close. This part is a little complex, but you'll
No,
show
it's
them how
not.
skillful
You
are.
sew the
So drill
flipping
3
thing.
small holes in the femur.
In a what? Oh.
Okay, let's suture hip capsules to the holes you just drilled. I'll suture the deep tissue, and you take the subcutaneous fat layer.
I'm just clicking buttons.
Now use staples to close the surface of the incision. Your technique, flawless. The OR team will bandage the incision and move the patient to the recovery room. Our patient will remain in the hospital another 2 to 3 days, followed by 3 to 6 weeks of recovery and physical therapy. The downtime will allow his muscles to heal and strengthen. Following that, our patient will have significantly less pain and a higher quality of life. One thing about this surgery that makes it great for younger patients is that it preserves bone, as you can see from this post-op x-ray. Thanks for helping out today, and good luck with the rest of your residency training.
That's nice. Alright, let's look at some real photos. Oh, that's nasty. Ooh. Oh! Holy guac! Here, let's look at it. This one. 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 And this one. Alright. Well, that was Ed Head's surgery. hip surgery. Yeah, thanks for watching. If this was too bloody for you and too gross for you, I'm sorry. I really wanted to make a video on this. But yeah, I'll see y'all in the next video. Thanks for watching. I hope you have a great rest of your day. I'm definitely not in 7th grade. Almost, though. Yeah, thanks for watching. And I'll make sure to make another one of these videos, except a different type of surgery. Thanks for watching.